There's a 65-year-old patient, Mrs. T, who arrived at the hospital to evaluate an asymptomatic carotid bruit. Doctors found a high-grade blockage in her left carotid artery. Doctors suggested she have an operation to remove the clot and prevent a disabling stroke in the future. She agreed to the surgery and let the nurse know that 4 years prior she signed a living will following the death of her husband. The day before the surgery, she stated that if any complications of the surgery were to occur, she wanted the living will to be carried through. She stated that life would be worth living only if she could be healthy and independent. In her will, she stated, "If a situation should arise in which there is no reasonable expectation of my recovery, I request that I be allowed to die and not kept alive by artificial means." She underwent surgery with no complications and woke up with full neurological functioning. 30 minutes later, however, she experienced right side weakness and neurological deficits compatible with a stroke. She went back into surgery where the extensive clot was removed. The operation did not reverse these neurological deficits, however. Miss T continued to have right side paresis and was eventually moved to the ICU for assisted ventilation. For several days, she lacked responsiveness, and team members began to question if the neurological impairment would ever reverse. To top it all off, she developed aspiration pneumonia and required a tracheostomy for ventilation. While some team members questioned the treatment against her advanced directives, her attending physicians argued that it would be impossible to predict how much function she would regain, given that she was only 1 week out from her stroke. One stated, "We must continue acute care, hoping for the best at this point." Even with this, others questioned if they should remove the treatment.
An advance directive is a document with legal authority in the realm of medicine. This document grants the patient more autonomy in their decision-making in the instance they are no longer capable of making an informed decision. An advance directive does this by allowing a patient to draft instructions for what is to be done to them in the event they are incapacitated, prior to such a state's occurrence. In other words, this is drafted when a patient is fully capable of competent decision-making. As stated, what primarily distinguishes that state in which a person can draft an advance directive to when an advance directive can be brought into effect is the difference in decision-making capacity in the individual. There are 3 components which allow us to determine that one is properly demonstrating decision-making capacity. The first component is that an individual is able to understand relevant information. The second is that an individual is able to evaluate the relevant information. And lastly, the individual is able to communicate their choices regarding such information. It is typically a lacking of the third component of decision-making, which is the center of the attention in various cases which an individual lacks advance directives, such as with Terry Schiavo and Karen Ann Quinlan. However, the first 2 components have also been shown to be a prominent factor regarding situations such as the theoretical case of the dementia patient, Margot. There are 2 courses of action which can be taken in this case. Either the advance directive should be strictly adhered to and aggressive treatment to Mrs. T should cease, or the advance directive does not clearly apply to the situation and the doctor should continue with aggressive treatment. We believe the latter to be true, and that the physicians, for the time being, should definitely continue with aggressive treatments to Mrs. T. We believe this for 2 main reasons, which are that Mrs. T's advance directive does not explicitly state the actions to take place in the specific circumstances she has fallen victim to, and that with this assumption, continuing with aggressive treatment is more beneficent to Mrs. T than following what is stated in the advance directive. The first point for going against what is stated in the advance directive is due to one of the most glaring downfalls of this document. This is that no matter how much preparation one does when completing an advance directive, as in trying to ensure with clarity that every possible question of what should be done next is answered, it is inevitable that not every possible scenario can be covered, as one cannot be 100% certain that a particular outcome will occur, because there is simply too much variability. And this is exactly what has happened in Mrs. T's case. Her advance directive specifically cited instructions for the cessation of life-giving procedures and technology if it would result in her not being able to live independently of such devices. What it does not state is that she should be omitted from such treatments if it were unclear what her future prognosis would be. As such, we can confidently say that her advance directive does not clearly state what action should be done in this particular instance. This is verified by the physician's statement that it was impossible to tell how much function the patient could regain. In accordance with Trotter's definition of futility, this statement clearly does not demonstrate virtual certainty that their goal, in this case independent functioning, will fail. Therefore, we know that the action of continuing aggressive treatment is not a futile action. Building off of this, our second point for going against what is stated in the advance directive is that it would ultimately be more beneficent to continue aggressive treatment with our current understanding of the situation. Beneficence, as stated in the Belmont report, is a moral pillar in bioethics. This concept makes it imperative that one should not incur any unnecessary harm to a patient in a healthcare setting, while simultaneously attempting to maximize the more positive outcomes and minimize the more negative outcomes. At this point, we do not know definitively what outcome will result from utilizing or foregoing aggressive treatment on Mrs. T. However, if we were to look at all possible outcomes which could come about if we were to treat or not treat Mrs. T, we could all agree that the best possible outcome would be that Mrs. T would be able to live independently of any life-sustaining devices or the after effects of life-deteriorating treatments. The only possible avenue towards this goal would be to continue with aggressive treatments, as following the advance directive would obviously lead to her death. In every way, independently functioning life is more beneficial to Mrs. T than any form of death. Knowing that there is a chance which is not currently futile to achieve this state, it is more beneficent and therefore more morally just to continue with aggressive treatments rather than adhere to the advance directive.
Some, like the team members assigned to this case, may argue that the treatment should not continue. They may argue that Miss T clearly does not want to live like this. With her friend's previous experience with stroke, she fully understands the diagnosis and specifically planned for it. Her wishes were not only clear and concise, but targeted to her exact situation. They may argue that any extra treatment goes against Miss T's right to die on her own accord. Another issue to address is that of paternalism. Paternalism is when healthcare professionals make their own choices for their patients without giving them a choice. Instead of treating Miss T as a subordinate, the doctor should trust that she understands the consequences of a stroke and made her wishes clearly known. Even if doctors are not sure what will happen down the road, her current state is obviously not in line with her personal choices. These arguments, though, are not robust enough to fully remove Miss T from care, we argue. While Miss T did state that she didn't want to be kept alive by artificial measures, she also has an instinctual desire to stay alive. While the treatment may keep her in an undesirable state for at least a little while, the doctors believe that she may be able to regain all of her function. Ultimately, isn't a life worth a bit of a fight? To the point of paternalism, this should not be considered paternalism to assume that Miss T would prefer a chance for life over death. In her own living will, she stated, "If a situation should arise in which there is no reasonable expectation of my recovery." However, in this case, there may be that expectation. Doctors should continue to fight to save her life. Once treatments are seen to be futile, they can stop the treatment, but until then, treatment should continue to fight for her life because we believe that she would want the chance to live.